Is the screen clear, doctor?
Yes, it's clear now.
Actually, there are about 1 minute, so we can start in 1 minute.
No, start now. The introduction
Okay.
will take about 1 minute.
Yes, okay, of course. Good morning, everyone. My name is Dr. Sarah Harith, a junior doctor, graduated from University of Baghdad College of Medicine in 2023. And I'm the moderator for today's session, which is, and this course is the Capacity Building a Medical Education course presented by the RCP Iraq London Network Medical Education Committee 2024. As we know, in this program is designed to enhance the skills and knowledge of medical educators in 4 Iraqi medical colleges, Wasat, Al-Amid, Al-Kafil, and Sulaimani. And the aim is to establish TOT group of medical education in 4 medical colleges. Target audience are faculty members of the 4 medical colleges as seniors, juniors, and medical students interested in medical education. And the platform that we use to engage in the activities is the Moodle platform. And it's actually important to remind you of the objectives. It's the most important to keep eye on it. And this module 4 is the assessment. The subject of it is the assessment. The learning objectives of the module. By the end of this module, the attendees will be able to design assessment tools that align with learning outcomes and apply best practices in providing feedback to support student learning. And the second one is to apply the monitoring and evaluation methodologies in medical education to ensure the equality and effectiveness of teaching. And the third one is to facilitate continuous improvement in training healthcare professionals. And to remind you that the requirements that are important for completion of this course is to attend at least 5 of 6 modules, participate in 3 pre-test and post-test, and to participate in the discussion forum, completion of the assignment of each module. We have today Dr. James Gray, which is MDCHB and senior fellowship of advanced in healthcare education, and the Fellow of Royal College of General Practitioner and Fellow of Immediate Medical Care from Royal College of Surgeon, and he has Diploma in Urgent Medical Care from Royal College of Surgeon Edinburgh, and he is clinical medicine, School of Medicine and Population Health, School Director of Recruitment, Course Director, Master and Master in Medical Sciences in Physician Associate Studies, Senior University Teacher, School of Medicine and Population Health, Sheffield University. This is for the first session for today. The Professor James will be the presenter. And the second one will be Dr. Mumtaz Patel, who will present in the afternoon. And today, actually, that I will just tell you about the timeline that we have, that my friend Sama my colleague will share the registration form that you have to fill in order to issue your certificate. And Dr. James will talk about first from high quality assessment management. And this is for about 45 minutes. Then we have 15 minutes question and answer. Then we have 10 minutes break. Then we will continue with Professor James talking about the assessment management and the blueprint and standardization of that. And then we'll have 15 minutes, that's for question and answer. And we have to establish ground rules that you have to mute your speakers. And if you have any question, you can raise your hands and there's a chat box. You can write whatever you want in it. And let's enjoy this learning session and grab your coffee or your orange juice and let's enjoy this. Professor James, the platform is yours.
Thank you very much indeed. That's very kind. Thank you for that very kind introduction. I think you've bigged me up extensively there. So I hope I can live up to that for you. So good morning, everyone, and good morning from Sheffield. I've had a look at the temperature with you in Iraq today, and I'm very glad that I'm in Sheffield. I'll be absolutely honest with you, where it's hitting about 20 degrees today, which is pretty good for our summer. So that's good. So today the plan is to talk about how we manage assessment, and what I want to do is take you through the process that you need to follow when building your assessments in order to ensure that you get that high quality that you're seeking to achieve. So why is it important that we go through an appropriate stepwise process? Well, first of all, having an effective process of assessment management is crucial to ensure that you can get robust summative assessments. And what we want to always ensure is that we're producing assessments that are fair to the students, but also are defensible from the perspective of the faculty putting those assessments together. So having a clear, robust, stepwise process to do so can ensure that we achieve both of those aims. So fair to the students, this is crucial. It's not about making it so that it's easy for the students or hard for the students. It's about making sure that it's fair to our students. It's about having this defensible approach so that if someone challenges, if someone appeals their exam results, we're able to say we followed a robust and appropriate process of blueprinting, quality assurance and standard setting in order to ensure that we are happy that the process has been followed and is fair. And I think this is crucial. It's also about providing reassurance regarding patient safety. It's got to be remembered that what we are doing in medical education is we are training the medical and healthcare professionals of the future. Those healthcare professionals are going to go on and treat patients. Patients want to be reassured that the processes that we follow are robust and are designed to ensure patient safety at all stages. So there are 4 key stages of assessment for me, which starts with blueprinting. Then once we've done our blueprinting and we have our exam construction, we move into the quality assurance phase. Following quality assurance, we have to think about standard setting, and standard setting may be pre-exam or almost post-exam, depending on the assessment we're using, and we'll talk about that. And finally, we have psychometrics, and I'll sort of talk you through some core psychometric evaluation that we use, which allows us to evaluate the examination afterwards and make sure that it has been, again, fair, but more importantly, discriminatory and valid within the assessment process. This is really important. No stage is more important than another. So we have to make sure that we treat each stage equally and appropriately to ensure that we can have confidence that everything has been done that needs to happen. So to ensure quality assurance and assessment, we have to make sure we robustly complete each stage. We can't, we mustn't rush through a stage or ignore any stage of the process if we're to get robust assessment. And I think this is quite useful to say there are ways to do some of these stages either synchronously or asynchronously, depending on your needs. And I'll sort of explain that as we go through what I mean by that. But for example, if you are doing an assessment that is only being utilized in a single university, and certainly if you are fairly new to these processes, you may wish to do them synchronously, where everybody does it all together in single meetings. Whereas once you become much more experienced, or perhaps if you're doing it across more than one institution, you may wish to do it asynchronously, where actually you can do some of segments of this across a period of time. And that can be very much dependent on your needs. So what we're going to do today is I'm going to initially talk about blueprinting and quality assurance. We'll then have an opportunity for questions and answers on those 2 areas. Then we'll have a quick break, and then after the break I'll talk a little bit about standard setting and psychometrics, and then again there'll be an opportunity for questions and answers. At the end of those 2 sections, I've also put in some useful resources, which are things that you may want to have a look at that can be helpful to understanding these different stages and to be able to look at in your own time. So in terms of blueprinting, so what is it? Well, your test blueprint defines the exam content and helps to ensure validity. A blueprint is, we are obviously all familiar with the idea of blueprints of buildings. Everybody's seen those films, haven't they, where the hero has to find his way through some pipe duct network due to the blueprint. But essentially, what is it? It's a plan that sets out a structure. So your blueprint for your assessment is the structure of your assessment. It's the way that you put your assessment together in terms of the questions and the subject matter of the questions. Now, crucially, it can be either a single test or more often it will be both single tests and across tests. And what do I mean by that? Well, what I mean by that is when you are planning medical assessments, it's rare that we have one single assessment that assesses things in a single year group, for example. So an example might be at the end of our first year of our medicine course, students have both the single best answer paper and a short answer question paper. It is not necessary to test every single element in each test. So a good example for this may be, we always find, for example, public health. Public health is notoriously difficult to write single best answer questions for, but they're not so difficult to test in short answer questions. Similarly, medical ethics, very difficult to write single best answer questions and much easier to write short answer questions. So it is not vital that the content of a year, for example, is tested only in what is tested in each and every test. It may be that we're testing what's been delivered in that year across a series of tests, and different tests will focus more on different elements. That's perfectly fine. It's also important to recognize that your blueprint will vary as the course progresses, and you test different areas of Miller's pyramid as well. And I'm sure hopefully you're familiar with Miller's pyramid, but I am about to remind you anyway. So for example, early on, if you are doing predominantly pre-clinical learning, you're not going to be needing to do OSCE examinations, for example, which are obviously quite practical. So those are going to have very different blueprints. So hopefully everybody is familiar with Miller's pyramid, the idea that we have these different levels of knowledge that we're seeking to test, and we do those in different ways. Now, at the bottom, we have obviously testing pure knowledge, which is fact recall. And here, of course, it has MCQ assessments or multiple choice questions. Now, certainly from our perspective now, what we tend to talk about is single best answer rather than multiple choice. It's a subtle distinction, but arguably the difference is that in a single best answer, all of the answers should be feasible in a greater scheme of feasible, whereas in multiple choice, there's very definitely one specific answer. But we can touch on that more either in Q&A or as we move on to sort of standard setting. Then we have knows how, so that's about interpreting and implying the knowledge. Case presentations, more sort of essay written work is a very good way of being able to test at knows how level. Then of course we have demonstrations, so simulation assessments or OSCE assessments, and at the top we have demonstrating that you can do, which is most commonly done through workplace-based assessment and under direct observation. So when we are defining our blueprint, there are 4 key stages to go through. The first one is we have to identify the knowledge and skills that we are seeking to test. And there are different things that will allow us to do this. So the first one is obviously your course syllabus. So the syllabus that you are teaching through the course and at any particular stage of the course. Second, maybe national requirements. If you have national guidelines, for example, particularly finals examinations in the UK, we have very clear, we need to be testing the whole medical curriculum. So that provides us with guidance. And then what we need to do is organize our required test content between the different assessments that we have, whether it's single best answer, short answer question, OSCE examination, etc. And we need to be clear in terms of what are we seeking to test in each of our different assessments. Some of it will be across both. Some of it may only be predominantly in one. That is fine. The easiest way I always think is think about blocks of knowledge. So if, for example, you are producing a blueprint for a first year examination, think about it in terms of what's the core blocks of knowledge that have been acquired through this year. Similarly, you also want to think about what proportion of time has been spent on different topics. A good example for us would be our students will spend 3 weeks of lectures on neurology. They'll spend 2 days of lectures on hematology in their second year. So clearly, we're not going to do 7 questions of both. That would be disproportionate to the amount of learning that they've done. We might have 7 on cardiovascular and 1 on hematology. Because it's important to remember that in any test, we're sampling students' knowledge. We're not expecting to exhaust student knowledge. It's impossible to do that in any assessment process without it becoming utterly unwieldy and vast. So secondly, when we're looking at once we've established what the knowledge is, we have to think about what our assessment objectives are. So again, this will vary depending on where we are within the course. So it may be that in the first year, the primary behaviors we're looking to establish is knowledge. It's about knowledge that's been acquired through the core learning that's been undertaken. Whereas as we move into clinical years, it may be that we're wanting to test in specific behaviors and skills in terms of the way students interact with patients, the clinical reasoning process that they are undergoing in order to come up with diagnoses. So they can be quite different, and different assessments, of course, suit those better. We need to be clear on the topics that we're assessing based on the learning. Is it just a single year's amount of learning? Is it cumulative knowledge? Again, that will vary. And particularly when we're talking about OSCE, we may be thinking about specific competencies or skill areas. So for example, breaking bad news might be a specific skill that we want to test in an OSCE. It may be that it is formulating diagnoses. It may be that it is explaining information. So for example, common breakdown may be that we want somewhere students have to gather information, somewhere we want to, which may be history taking and differential diagnosis, somewhere we want them to give information. So it may be explaining contraceptive options, for example. And it may be as well that there are a list of specific medical conditions or presentations that you want to test. And again, your blueprint can go to the level of granularity that you wish. You can make it as detailed as you want. Our third thing then is deciding on our assessment formats. You know, going back to that Miller's pyramid, now that I understand what I'm trying to test, I can go back to Miller's pyramid and go, so what are the best ways of testing that? So knowledge is going to be through our single best answer style questions. It may be during the year that we want to do some essays, for examples, which allow us to think about application of knowledge, an interpretation of information. In clinical years, it may be we're thinking about simulation assessments or OSCE assessments. And then, of course, what we do is, having gathered all of this together, we need to weight each category. So how many questions are we going to have in our test, or stations in our OSCE, whatever it may be? And then we need to define the number of questions for each of our topic areas based on importance. Now, importance is always one of those difficult words to interpret. One clinician's important may be different to another clinician's importance. And something I'll talk about again later on is we must make sure we don't fall into the trap of thinking that our area is always our particular area of clinical interest is the most important area, or the area which we have taught the students is the most important area. When we're building assessments, we're building assessments for the course. So it needs to make sure that it samples across appropriately. And as I say, for me, I often think that looking at the amount of teaching time that has been spent on different blocks of knowledge can be quite a good guide as to the questions that are in. It may also be that there are particular topic areas that are of particular importance because of your own healthcare system and disease presentations. So whilst there will be plenty of presentations that are common, for example, between Iraq and the UK, for example, heart attacks, strokes, etc. There were maybe other presentations that we see very little of and you see a lot of, and vice versa. So it's important to reflect that our blueprints may not reflect what's needed for your examinations and your healthcare system. So it's important to think about that as well. And then, so defining those question numbers, as I say, my general guide, first of all, is look at how much teaching there is on the different areas and whether you break that down into, say, cardiovascular and respiratory and gastrointestinal, etc. Crucially, you don't have to test everything. We are sampling the students' knowledge in these assessments. I did an assessment recently, and I had a very interesting comment from a student who said, I was stunned there was no question on multiple myeloma. Well, there was a question on multiple myeloma, but they just didn't realize it, which perhaps is more of a concern. But the reality is that there may not have been, but there may have been a different hematology question, and that is fine. If you think about the sheer amount of knowledge that students are acquiring, it's highly unlikely that you're ever going to be able to sample every single thing that they can possibly have learned. So it is about a sampling, and our blueprint allows us to ensure that our sample is representative of the teaching that the student has had. And then again, I'll reiterate this point. Remember that our weighting may be across a number of different assessments. So it's not that each individual assessment in a year, for example, must have the same amount of knowledge tested of each different area. It may well be that it is a situation where certain things are better tested in one exam versus another. I saw a hand go up there. Was there a specific question on that point, or was it an accidental button press? That happens to me all the time online.
Yeah, I think, Nazar, you raise your hand. You have anything, or it's by mistake, Dr. Nazar? No, I think it's a mistake.
Not a problem.
Yes,
Yeah, it's not a problem at all. Don't worry, it happens to me all the time. So, crucially, if we follow these 4 steps, what we'll be able to do is create a clear blueprint for our examinations. And then the level of detail that you put into your blueprint is really a choice for you and depends on the examination. I think this is a really important bit here. It's fine to share your blueprint with the students, okay? It shouldn't be a secret. Students should be aware of the blueprint that we use. Though what I would say is the depth of sharing is up to you. If you have chosen to define for your blueprint for a year exam the exact topic of every single question, you may choose not to share that with the students, because clearly then they can ignore all the other topics within, say, cardiovascular medicine that are not on those exact questions. But sharing with them, for example, that there will be 8 questions on cardiovascular disease versus 2 questions on hematology versus 9 questions on neurology is perfectly okay. These things should not be a secret, but you perhaps don't want to say those 7 cardiology questions will be heart failure, myocardial infarction, pericarditis, etc., because then they can simply ignore everything else that's been taught, and that's not necessarily going to aid in the whole process of knowledge acquisition. So this is just an example. This is the year 1 single best answer examination for physician associates here at Sheffield. And we share this with our students. So you can see general, so pathology, immunology, 6 questions, pharmacology 3, there's 100 questions. So musculoskeletal, for example, there's 6, neurology 7, there's 1 dermatology question. So you can see the way that that's built. And you can see at the bottom, ILA clinical seminar related 21. So they have a series of problem-based learning sessions and clinical seminars. And they know what all those seminars are, but over those 21 questions, we're not going to necessarily sample each individual one, but they can see that that's an important area. So they need to make sure they revise all of those topics in detail. Now, one criticism you sometimes get is, well, if I see there's 1 hematology question, then what's the point in me learning hematology? Because for the sake of 1 question, Why would I waste my time? Now, you will get some students who will take that sort of approach, but we have to recognize that all examinations are open to a degree of gaming, as we would put it, or playing the odds. Clearly, if that one question is the difference between them passing and failing, that's a problem for the student. But on the other hand, the reality is that we know that they are going to look at the subject areas and go, look, we did very little of that. I'm not going to focus my learning on that. So perhaps, in my opinion, I don't think we're necessarily causing any issues by that. And we should be transparent and open with the students in terms of how the exam is going to be constructed. Now, hopefully this will work. Can you see that? I can't quite, just let me see.
Yes, it's clear.
Yeah, brilliant.
Just make it larger, please, James.
Oh, yes, of course, I can do that. So this is an example of an OSCE blueprint. This is Physician Associate National Exams, but I got it because it's a national document. So it's useful to say that if you do have exams within healthcare, because they're not just medicine when we're thinking about healthcare, that have national guidance, you may choose to follow that, and we use this as our OSCE blueprint, and they detail what is there, and they say we have 4 broad skill areas: communication, examination, procedure, and emergency management. And then they go on to break down and say 40% will be communication skills, 30% examination, 20% procedure, 10% emergency. So this is providing that breakdown and guidance. And indeed, they provide further guidance about, so within the communication skills, that these are possible things that could come up. Now, you can see that not all of these are going to come up in a single OSCE. But the whole idea is that you're giving that guidance to students as to the type of station. Again, it doesn't have the topic here. Breaking bad news could be, it could be the classics, you've got cancer, your relative has just unfortunately passed away. But it can also sometimes be slightly more subtle. It can be new diagnosis of diabetes, for example, which is always one that we do. Sometimes students don't actually seem to realize that it could be a bad news. Actually, when you look at the complications of diabetes, I'd consider it to be really bad news. But actually, so there's all those things, dealing with conflict, information giving, and telephone communication. Certainly, this is something we see a lot more in OSCEs in the UK now, with a significant increase in telephone consultation and things like that. So it's about providing that blueprint guidance, and then within your detailed blueprint that you construct for your examination, what will happen is you will have selected elements of this to build the examination as a whole. So hopefully this helps you see how the blueprint you share with the students is not quite the same as the blueprint that you will have for your examination. So, okay. Oh, I think, have I gone backwards? No, that's fine. So yes, it's perfectly acceptable. So just to sort of finish off about blueprinting, it's perfectly acceptable to have a high level of detail if you want. So that's specific topics for each question. And when you are building your exam, it's very important that even if you don't have exact topics set out in your blueprint, you record the topics that you are putting in so you don't end up with duplication. And certainly, as I'll mention when we go on to quality assurance, when you're going out to question writers, it's important that you are specific about the topics that you are looking for your examination. Finally, blueprinting does not consider the difficulty of the questions. Okay, that is part of your quality assurance and standard setting process. So we don't need to worry about how difficult questions are at this stage. Our focus is on the topic blueprint construction. So that's an introduction to blueprinting, and I'll later on, one of the slides later on, there's a link to a very good article that sets all of this stuff out about how to build a blueprint. But it's not rocket science, but it is about getting it right in terms of the amount that we're focusing on each individual topic. So I'm going to talk now about the next stage. So which is quality assurance. We need to make sure our exams are of high quality in order to, again, ensure that they're defensible and appropriate. So first of all, we need to define the questions we need. We've talked about our blueprinting, but also you will potentially have question banks. And so you may wish to be pulling some questions out of question banks, but you will inevitably need new questions. So once we need to define the questions we need. And this, again, is another really important bit. And this can often be the biggest challenge when we're going out to question writers, which is we need a consistent format for whichever test type we use. So questions should be constructed in the same way, whichever type of question we're using, whether it's SBA, whether it's SAQ, whether it's OSCE, etc. So in the UK, a good example for SBA is we follow the Medical Schools Council Assessment Alliance guidelines on exam question structure, which will be that it should be, and it has a STEM, which is the information. It has a lead-in, which is, which of the following is the most likely, etc. It has 5 answers, which will be presented in alphabetical order, and one of which will be the best answer. So we have, and there are very clear guidelines. For example, we should never have negatively phrased questions. So which of the following is not. That is not good practice. We shouldn't never have all of the above or none of the above as an option. Again, that is not good practice. So, and those are freely available on the internet. You can find, if you look at Medical Schools Assessment Alliance or MSCAA question writing guidelines, that's all on there. And that's what in the UK we would use as best practice. And it's important to share that. Similarly, there are standardized reference ranges as well. Even across the UK, we'll see different reference ranges for different tests. The Medical Schools Assessment Alliance produce a standardized list. So once we've got that and we've constructed the paper, we need to review the paper in detail. So your blueprint will have set that out. We've got our exam bank, but it's good practice to have a proportion of new questions every year. I would say that there is no set number of new questions that you need. There is no guideline that says you must have 20% new questions each year. That will depend upon your own guidelines, your confidence and security of your exam bank, and whether you release past papers and things like that. We then often will go out to our faculty to write questions. It's really important that they know who they're writing questions for. Questions may be quite different if it's first-year exams versus fifth-year exams, for example, different expectations of knowledge, understanding, and what we require in terms of students being able to progress to the next stage. Similarly, if we're going out for questions, it's really important to make sure that our faculty are invested in doing this. One of the biggest frustrations you can find is that you ask somebody to write a question, they write a question, they send it back to you, and they think the job is done. Whereas for me as a course director, I will review that question, I will provide comment and critique against the structure of the question, how it's supposed to be built, and I might send it back and say, look, this isn't quite as the structure, here's what I think we should do to change. What do you think? Because that individual is the one who has constructed the question. Or it may be that I look at the question and go, what guideline is this based upon? Because it's really important to remember, we cannot build questions based on what we think is right. We have to build questions based on what the evidence says is right. So clinical guidelines, clinical evidence, and not just I saw a patient once and did this and it worked. That's not good practice, because if it's based on gut feeling, it's not. We can't teach it. It's really important, therefore, that we review all these new questions before putting them in the paper, and indeed we review old questions because things do change. So we have to ask ourselves, is the structure of the question correct? Has it followed the best practice guidelines? And having a sort of one-side A4 sheet of guidance on here is the key way we want you to construct the questions. And structure also includes things like avoiding unnecessary information, window dressing, as we would call it. So in avoiding putting in information that is not relevant to answering the question. If it's not relevant, it shouldn't be in there. Is the difficulty appropriate? Now, we need to be cautious about saying, is it a hard question or an easy question? That's not necessarily a problem. That comes out in standard setting. But actually, is the difficulty such that it is something that really hasn't been taught, or takes a topic to a depth that is beyond what is expected at this stage? It can be hard as long as it's at a level expected at this stage. That's not a problem. But if it's an element of obscure information that is not appropriate at this stage, then that's a problem. So we need to make sure we don't end up with those sort of questions in our paper. Is the way the topic is framed in line with expectations? So essentially, has the way that the question has been constructed fit with our expectations of that, the level of that topic has been taught? Has it been, and the way that has been taught? So we're not, and this can be a challenge if we have people, for example, who are writing questions who didn't teach that particular topic. That sometimes you get it framed in a way that the students haven't been taught, and they can find that quite difficult sometimes, particularly earlier on in their clinical education. So it's quite important to reflect on that. And most importantly, has the question met the brief? If you asked for a question on heart failure and you get a question on pericarditis, then the answer is no, it has not met the brief. So it's really important to check that that is the case. So once you have all the questions, one person should construct the paper. Now that could be the year group lead or course director or year group director. It could be an admin person who's been clearly provided with the blueprint and can construct it. It's whatever works within your system. The idea there is it's constructed and you can ensure that the paper meets your requirements. So that when you've put it all together, you're happy that you have the spread of questions and the spread of topics that you originally designed from your blueprint. Now, for me, it also allows for an initial, what I call pre-quality assurance. So quality assurance should be a formal process, but the pre-quality assurance is essentially that initial look for any glaring errors that are obvious within the paper. And for me, whoever is taking primary responsibility for that assessment has the responsibility to review the paper first and edit and manage any glaring errors. Now, you won't pick up all of them. Having done it many, many times, you will still go to your formal quality assurance and not pick those up or not have picked those up. And that's fine. Okay, it's a process that it develops, but at least you will be able to pick up any glaring errors. And that just simplifies the process. It can make the process less time consuming. So then we move into our process of formal quality assurance of our exam papers or OSCE stations circuits. Now, this can be done either synchronously or asynchronously. I generally recommend that if you are fairly early on developing your course team or similar, that you do it synchronously. So everybody sits together, either face-to-face or increasingly online, and goes through the paper question by question, looking at it and making sure that each individual question is constructed in the way that it should, checking for typographical errors, checking for syntax errors, and making sure there isn't that additional unnecessary information, etc. This is really helpful when you start out because it allows you to get a good, clear feel for the process and understand how to do it. As if you are working with an increasingly experienced team, then an asynchronous approach is perfectly acceptable. That's what we mostly use now in Sheffield, where our exam papers are put onto a Google Doc. We use Google Docs because multiple people can work on the same document at the same time. I probably should do the, other online options are available. And each individual works through the paper and adds comments or edits. And then the sort of assessment owner can then agree with, approve the edits or the comments. And at the end, there's a short meeting for any areas of contention. So anywhere where there's several comments about a question, you can then bring it together. But it means that all the simple editing, the syntax, the spelling, etc., or if somebody highlights something and says, I don't think we need this in, for example, the lead can go, oh, yes, you're right. Yes, I agree, and edit it. So at the end, we can have a shorter meeting. So synchronous is very good early on, very good to learn the process, to really get a feel for it. But if you have quite an established team who are very experienced at doing quality assurance, asynchronous works really quite well as well, and allows the advantage of doing these things asynchronously is you can have a shorter meeting, and it's often easier to allow people to do the quality assurance around the other commitments that they have in their day-to-day lives as working clinicians or academics. This process is the same regardless of what exam type you are looking at. So it doesn't matter whether you're looking at single best answer questions, short answer questions, OSCEs, it should be the same. So obviously I've talked about sort of single best answer questions and the idea that there we go through, we look for syntax, spelling, etc. But it's no different for an OSCE station. Our OSCE stations should still have the same format, whether it's, it may be the subject matter of the OSCE station, the information for the student, the information for the examiner, the information for the actor or patient. And each of those sections should themselves have a clear structure. So it should be, for example, we would normally expect in the section for the examiner, it would say, this is the information that the student has received. Here is what we expect of a excellent student, a good student, a satisfactory student, a borderline student, a fail student, so that we're providing that clear guidance to our examiners at all stages. That we have a mark scheme with our marking grid, with the points allocated across the marking grid, and an appropriate number of points allocated to each individual section. And this is where, of course, we can weight our OSCEs. So it may be that we'll have a lot more for information giving if that's the focus of the station, and less for other aspects. The whole point of doing this is to ensure that consistency and high quality examination. So consistency is key. It is not good to end up with an exam that has a massive variation in the style of questions that are being asked. They should be internally consistent within that exam, whether it's any exam type. Short answer questions should still have a clear structure and an initial stem with the questions below them, with clear allocation of marks to each of the individual sections, clear guidance for examiners in terms of what are the correct answers and similar. Now, for quality assurance, you don't need a big group. So we normally reckon 4 to 5 is more than enough. If you have more than that, you can end up in situations where you actually go round in circles debating the same small area too many times. So we've usually used no more than 5, often about only just 4 for quality assurance, which should include obviously a year group expert to ensure an appropriate level of question. The other thing we found very useful, we often include somebody who is not a medic. And we have one of my colleagues, David, who's one of our psychometrics team. He is brilliant because he picks up every grammatical and syntax error that we miss because we're more focused on the clinical content of the question. So it can be really helpful to have somebody in your quality assurance who is picking up those bits and pieces, which otherwise we might have missed. One of the things I sometimes get asked is, why do we put the answers in alphabetical order? Well, answers are put in alphabetical order because it used to be that what would happen is you'd do an exam paper and you'd go, right, I need to have about 20% that are A, 20% that are B, 20% that are C, 20% that are D, and 20% that are E. The problem with that, of course, is if our students get to the end and they've left a bunch of questions unanswered, they can look back and go, right, I've already answered 20 questions with A, so those answers are probably not A. So they'll use that to guide their, should we say, guesswork on questions they find difficult. So putting them in alphabetical order removes that. It removes that that element. It'll be, so the answers simply fall alphabetically. So you may not have the equal distribution of A, B, C, D, and E answers. That's fine. The correct answers are still there. So that's just something that's worth being aware of. And as I say, year group expert to ensure the appropriate level of question. Again, this is not out whether it's an easy question or a difficult question. That comes out through the standard setting process. This is about, is it a fair question for the year group, what they have been taught, and our expectations of them at this point in the course, because that will change. And again, when we come on to standard setting in 15 minutes, 15, 20 minutes or so, that is where the difficulty element is brought in. And it comes out in the wash in standard setting. The great advantage of standard setting using best practice in medical education is that if the paper is harder, the pass mark goes down. If the paper is easier, the pass mark goes up. So it all works out and ensures that we're doing the right thing by the student. So that's really emphasizing that. And remember, standard setting deals with the difficulty of the exam, not blueprinting, not quality assurance, standard setting. So in that early stage, all you're caring about is right level of question, not hard or easy. So to summarize that first bit, our initial blueprinting supports a robust exam structure. So that ensures that we can produce an exam structure that is representative of the teaching that the students have had. Quality assurance has core stages, which starts from going out for new questions, ensuring that people understand the right structure for questions of whichever exam they're writing for, and then the process of actually going through the paper in detail to ensure that it meets our expectations. It is very important to ensure identical question structure through a paper, and I would recommend that if there are no specific guidelines, that you ensure that you have guidelines for that. As I say, the UK ones are freely available for single best answer questions online. And finally, the final quality assurance process can be synchronous or asynchronous to suit your own working patterns and how you feel it will work best for yourselves in terms of managing it around the other things that are demands on your time. So I think that's just about bang to time. So I'm very happy to take any questions that anyone might have.
Thank you very much, Professor James, for this valuable and thought-provoking information. And please, if anyone have a question, please raise your hand and you can write in the chat box. Professor Hilal, please, the mic is yours.
Thank you very much, dear James. It was very interesting, enjoyable presentation. Really, I enjoy it. I have two short questions. The first of all, who is going to do the blueprinting for a course, for a year, or for the whole college? Who is in charge? And who is going to revise that blueprinting, whether it is of higher quality, representative really the content, beyond the content, less than the content? That is the first question. And the second question regarding the question bank. Usually the recommendation is that to give feedback to the students after finalizing the exam. So are they will be able to answer the questions, difficult questions they encountered? And if the case is so, should that question be removed from the bank? Because you cannot use it again. It's related to how many times you are able to use a question. And thank you very much, James. Really, I interested your presentation.
Thank you. So in terms of the first question, my general feeling is that depending, part of it, of course, depends on how you structure your faculty, but For us, we have a year group lead for each of our year groups, and we would expect the year group lead to construct the blueprint for the assessment. So for that particular year group, because they are the experts on the content for that individual year group. So we would expect them to be in charge of constructing that blueprint for the examination. It would not be the course director, because the course director has oversight on the whole course, unless the course director is also is also a year group lead, for example. So that would be my general view on that. On the second question, sorry, just remind me, Halal, what the second one was.
The second is that who is going to review the blueprint papers after construction?
Yeah. So for me, that is the year group lead, but I would also expect that. So we certainly have an assessment group which reviews all of our exam processes and structures. And if there is a change to the blueprint because of a change in what we do, then we would expect that assessment group to sign that off and approve that blueprint is suitable for the year. So essentially, if you like, the year group lead would present the case for changing the blueprint or the case for the blueprint, and would then it would be signed off at our assessment group.
And for the feedback after the examination?
Feedback after the examination. We feedback based on topic. We don't go through the question with them. So we keep the questions secure, but we would say there was a question on pericarditis, you got it right or wrong. There was a question on heart failure, you got it right or wrong. There was a question on basal cell carcinoma, you got it right or wrong. And so we would give them that level of detail, but we would not go through the question with them. So we would maintain the integrity of our bank. Though it is good practice to provide some sample questions so that students can have an idea of question structure. And it may be that you feel that once your question bank is big enough, you can release some past papers and retire some questions. That's not unreasonable as well. There is a school of thought which says if you had a question bank of around 4,000 to 5,000 questions, you could just make it an open question bank anyway, but we won't go into that.
Thank you very much.
No problem.
Professor Nazar, please unmute yourself.
Yes, thank you very much, Dr. James, for your wonderful presentations. Actually, I have 3 questions regarding the blueprint.
Yeah.
My first question is there any rule for Bloom taxonomy in creating an exam blueprint? Should I consider if the exam questions are designed for recall, comprehensions, or applications? My second question is, when you create an exam blueprint, it is important to determine the most important topics. Is there any good practice of that? Can I use the principle of the day one doctor as a way to determine the importance? And how you often you update the blueprint? Is it yearly? And thank you very much for your
No problem. So in terms of Bloom's taxonomy, what I would say is that will very much depend on the stage that you are at in the course and the subject that you are trying to assess. So for example, anatomy by definition is right or wrong, whereas clinical questions often by definition are a grey area. We know that there are more than one way to manage different clinical problems. So I think that it does depend on the stage you're at. Similarly, so anatomy, physiology, the core sciences are likely to be more typically multiple choice, whereas when we're doing things like single best answer questions, it is likely that we are going to be doing questions that require more comprehension and application. You can use Bloom's taxonomy. Mostly, I would suggest that it will be defined by the subject matter. Certainly, if we're writing questions about clinical questions, that's why we do talk about single best rather than multiple choice. So an example might be a question that is related to gout. our answers for treatment may be non-steroidal anti-inflammatories, colchicine, prednisolone, codeine, and then the difficult fifth answer that we all struggle with. And of course, technically, non-steroidals, colchicine, and prednisolone are all acceptable treatments of gout. The UK guidance would say non-steroidals are first line, colchicine and prednisolone are second line. If you be put in the question that the patient has asthma, we're expecting the student to comprehend that they shouldn't be prescribing non-steroidals, and therefore would probably go for colchicine, would probably be considered the best second line. So we're testing comprehension rather than pure recall. I don't think that pure recall questions are particularly effective, particularly unless it's relevant to the topic like anatomy. The reason I'd say that is I believe firmly we should not be testing recall on stuff that we'd expect people to be able to look up easily in their clinical practice. A good example would be drug doses. And to give an example, then almost a counter argument, I don't expect my students to hold pediatric antibiotic doses in their head. I expect them to look it up because that's safe for patients. On the other hand, I do expect them to hold the fact that if someone is in anaphylactic shock, that they are treated with 0.5 mils of 1 in 1,000 adrenaline, because I don't think it's fair on the patient to wait while my student looks that up. That is clearly a medical emergency. So I think that's a slight difference there. In terms of important topics, that really is defined partially by yourselves. I don't think any one topic is more important than the other. I think it's about saying that you are comfortable, that you have an appropriate sample across the subject matter that has been taught. So again, you may say that your standard blueprint, and this goes back to this question about how often do you have to change the blueprint. You may have a standard blueprint. For example, I will have 9 cardiovascular questions in my exam, but then year on year, you choose a different set of 9 specific topics, sampling across the curriculum that's been taught on cardiovascular medicine. That's not about saying one is more important than another. And also we have to trust to the fact that over the whole course, we are likely to be sampling across pretty much every clinical topic. And that's always the challenge, that we design assessments for a single year often, but we need to think of them in the plurality of all 6 years. The day one doctor is 100% a good way to think about it for your finals exams. But I would suggest that when we're talking about year one exams, that's not going to be the right level, because they're not there yet. So for your final exams, 100%, what do people need to know to be safe on day one? And in OSCE terms, what they're able to demonstrate to be safe on day one. That's really important. So yeah, I think those are the questions. I think those are the key ones there, hopefully.
Thank you very much.
Thank
Greatly
you.
appreciate it.
Dr. Shara, please unmute your mic.
Hi, everyone. Thank you, Professor Gray, for your time and informative presentation. I have a couple of questions. The first one of the issues that we are facing, and some of the, of course, smart students complain about, is on the subjects. For instance, in your example, you said hematology has 1 person, for instance. The student can complain that once they see blueprint, they won't even go through the hematology part. So if we have a solution for that, for instance, out of these 10 topics, at least the student need to pass 6 of them, regardless whether it's 1% or 10 or so on. Would that be sort of a solution for that?
It wouldn't be considered best practice. It's a really difficult one, and somebody's put in the chat, what do we do for those students who ignore topics with only 1 answer? There is a blunt reality that we have to recognize that students will sample in their own revision, whether we like it or not. And that goes at every exam, at every level. I'd see that in postgraduate examinations as well. Students recognize that they can, fail in inverted commas, and not perform well on a single topic as long as they do well on other topics. I don't think there's an easy solution for that. Clearly, there's a degree of trusting professionalism, but I think it is an interesting question. You then have to reflect back against what do you need to know as a day one doctor? Actually, probably the minutiae of hematological conditions, which we don't see that often unless you're working in hematology, may be less important than cardiovascular disease, which we see frequently across, well, certainly we do frequently across all areas. So I don't think there's an easy answer, is the honest answer. You could go down that route, but the risk you make is producing what's called killer questions, because unless you are prepared to have the same number of questions for each topic, which doesn't actually reflect clinical reality, then what you risk is creating a handful of questions where if the students don't get them right, they fail the exam. And that's not good practice. It's similar in OSCEs. You're not allowed to have killer marks. So the student can perform incredibly well, but they forget to do one thing and they fail the station. That's not considered good practice either. So I would say it's probably what we would affectionately call a wicked problem. It's not easy, but I suppose I'm a pragmatist. We have to accept that students will always look at ways of playing the system to a greater or lesser extent.
Correct. Thank you. We were all there one day.
Yeah.
Thank you very much, Dr. Shara.
If
Dr.
allows me, I have another question.
Oh,
Time is
That's fine.
okay. What's the other question?
Oh, sorry, I thought we don't have to. Okay, so we have another issue. Usually when we prepare sets questions for the final exam, we have to prepare two sets for first trial and second trial. Usually it's sort of difficult to prepare two sets as per the requirement. There should not be any question repeated, and they should all meet the requirement. So how we can deal with that? Is it better to prepare both sets at the same time, or prepare one set for the first trial and then accordingly we study the outcomes and then prepare sets for second trial? Or is it better, based on your experience, to prepare both of them at the same time?
I would always prepare both at the same time.
Yeah.
Not least for your own sanity. And also because of the fact that you may not have a huge gap between the two papers. So you put yourself under immense pressure if you try to prepare your resit paper straight, sort of in a very small gap. So I would say prepare both of them together. It allows you to have a feel for what topics are in both papers as well. And it's also important to say it's okay to have the same topic in both papers. You just can't have the same question. Common things are common. So we would expect, for example, in a clinical paper, you're going to have questions on asthma, heart attack, etc. in both papers because they're common. You just shouldn't have the same question. So it's perfect. I would always prepare them at the same time, well in advance, and hope that all the students pass first time, in which case you've got a spare paper for next year, which is always the warmest feeling you can get.
Yeah, regarding the difficulty of the questions, the level of difficulty, if it is guided in the blueprint for the faculty, just to have, for instance, 60% sort of easy question, 30% medium difficulty, and then 10% hard. That way wouldn't be easier. I know you keep emphasizing on the blueprint. We do not need to worry about how easy or difficult the questions, but wouldn't that help in any way?
I'm going to park that until we've talked about standard setting in the next section, because that hopefully will make it all become clear.
Thank you very much. And actually, we'll take one last question from Professor Batul Yassin. She is saying, do you have only one end year or semester summative exam for grading students?
Sorry, what the question was? It in the chat box? Oh yeah, here we are. So it depends. So we do have summative assessments through our year, particularly in terms of some essay type work. But we primarily have an end of year summative examination, which is what assures progression to the next stage of the course. We are currently looking at the idea of more formal programmatic assessment. It will require a bit of a change in our regs, but we are looking at that. But primarily, we have an end of year semester summative examination. And there is an argument to say that high stakes end of year examinations have an element of hidden curriculum, in that often in clinical practice we're having to make high stakes, time limited decisions for the care of our patients, and therefore it's not dissimilar to being put under that having to make a decision at the end of the year pressure. But yes, that's what we primarily do, but we do have some other summative elements that are required, which range from essay type work through to very simple things like a requirement for 80% attendance, for example, which is a summative requirement to pass. But the primary element in most cases is an end of year or assessment or year period examination.
Thank you very much, Professor James. Now we will gonna take a 10 minutes break. So you have to be on time, on Baghdad time, which is like 14 minutes. Thank you very much.
Thank you. I'll see you in 10.
Yes.